Hi, I'm Andrew Penn. I'm a psychiatric nurse practitioner and an associate clinical professor at the UCSF School of Nursing. And in this module, we're going to talk about ADHD, starting first with epidemiology and the neurobiology of ADHD. So we're going to understand this illness across the course of the lifespan and discuss the neurocircuits that we think are involved and the neurotransmitters that are involved in ADHD, and talk about how medications will act on those particular targets. So when we're diagnosing ADHD, we need to think of a number of different aspects. So first of all, that there's a persistent pattern, not an intermittent pattern, but a persistent pattern of inattention, which is not willful. So it's not the result of defiance, or that the person doesn't understand what we're asking them to do, but that they are simply just distractible. And that they may or may not have hyperactivity and impulsivity. This is more common in young people than it is in adults, although hyperactivity can be noted in adults, and this is often seen as a kind of fidgetiness, whereas children can be literally hyperactive, running around. I used to have a throw rug in my office, and a lot of times when I was done seeing a patient with ADHD, the carpet would actually be kind of bunched up and rumpled because of the person fidgeting with their feet on my couch while they were coming to see me. So that was how hyperactivity would sometimes manifest in adults. And of course, this hyperactivity or attention deficit needs to interfere with the person's ability to function in their key roles. So if they're a student, they may be having educational problems. If they're working, they may be having difficulty with their job functions. It also can manifest at home and in relationships too. A lot of times people with ADHD are accused of not listening by their partners because they're inattentive to the conversation. And it's also got to happen in more than one setting. So just because you're distractible at school, but you're fine at work and fine at home, is not likely to be ADHD. It's probably more, says something more about how you feel about school. And then it also helps to get confirmation from third parties. So teachers, colleagues, friends, family members. Now, ADHD is pretty common. Spend some time in a preschool and you'll see a lot of what looks like ADHD. You'll see kids running around. You'll see kids distracted. You'll see kids forgetting to do things. And so in a way, we all kind of have ADHD when we're children, when we're very young children. But as our brain myelinates, and it myelinates from the back of the head forward, the last thing to get myelinated are the frontal lobes. And it's really in those frontal lobes where the main wiring for our capacity for attention, focus, and being able to hold still really comes from. And so some people just grow out of these inattentive problems as they get older. And then, by diagnostic definition, you have to start showing these symptoms after about the age of 7. So really, this is present in many different children, but as they get older, the problem is they start to separate out between kids that have these problems with attention and kids that don't. And for the kids who are having this, they're not keeping up with their peers, or they're not developing the capacity for attention. They really often can run into academic and behavioral problems, and this can kind of set up a cycle of feeling like a failure. Sometimes the lack of ability to inhibit speech leads to inappropriate behavior with peers and saying things that leave the kid feeling embarrassed and feeling out of the circle. As we get into adolescence, there's a comorbidity with beginning smoking, and again, problems with academic and behavioral achievement. And this can again feed into that negative feedback loop of that the person is incompetent and unable to achieve life goals. And so if you're seeing an adult with ADHD, they should, by diagnostic definition, be showing symptoms in childhood. And it's not uncommon that people will tell you, it was right around the beginning of high school or in middle school that I really started to notice that I was different than a lot of the other kids, and that teachers started to saying I wasn't living up to my potential. It's useful when we're doing an ADHD screening to use a standardized screen, something like the ASRS, This is a self-report scale, and as you can see, the way that they've set this up is if you get 4 or more checks in the gray boxes here, this would trigger a greater series of questioning around ADHD. So you can certainly screen for this in your outpatient clinical practice. And if this does check positive, it doesn't necessarily make the diagnosis, but it would be reason to ask further questions about how these have impacted their life up till now, and possibly to get concomitant information from friends, colleagues, or family members. Now, what should we treat first? Well, if substance use disorders are present, we need to treat those first, and also mood or anxiety disorders. Now, the problem is a lot of adults with ADHD never get past the treatment of, who have ADHD, never get past the treatment of the mood or anxiety disorders, and that's where we stop. And sometimes when somebody's mood or anxiety is addressed, we notice that they have problems with attention, and we should think about ADHD at that point. Now, many kids, their mood or anxiety disorder symptoms may be attributed to ADHD, and so we start at the ADHD point in this circuit here, and really we can overlook problems with anxiety and mood disorders, which we need to be attentive to if we're being asked to assess a young person for ADHD. Now, where does this live in the brain? Well, you know, at the risk of great reductionism, which I'm going to invariably commit here, the prefrontal cortex, really the front of the brain behind the eyebrows, behind the forehead, is really where many of these functions of attention, behavior, and emotion reside. And it's thought that under function of these circuits is what leads to ADHD. So you know, it makes sense that this would map onto this area of the brain. And when I'm doing patient education with a patient who has ADHD, I'll explain, you know, this is like the filter. And so, you know, if you imagine yourself in a big college classroom and you're sitting in the back, and the teacher really takes up like 5% of your visual field, and that's what you have to track. And you need to screen out 95% of what's happening around you. And you have to pay attention to only what the teacher is saying, and screen out the fact that somebody is chewing gum next to you and the guy on the other side is tapping his pen, and that somebody in front of you is looking at their phone, and your eyes are darting all over the place to all these different stimuli, and they're not paying attention to the stimuli that matters, which is the teacher's lecture. Like hopefully you're paying attention to mine right now. Now, if we have not enough dopamine or norepinephrine in the prefrontal cortex, we find ourselves fatigued and struggling with attention, right? Now, we want to hit this sweet spot. So when we're giving an amphetamine type drug, we are increasing the levels of dopamine and norepinephrine. And there is a sweet spot. So if we undershoot, the person's still going to have symptoms. Interestingly, if we overshoot, we actually cause problems with attention and focus. So if you think about somebody who's had way too much stimulant, maybe somebody you've seen in the emergency room who's taken a bunch of methamphetamine, they are not focused, right? They're very distractible. They're hyperactive. They're difficult to redirect. So they're where that purple dot is there, they've really overshot the mark. So really with stimulant treatment, which I'll talk about more specifically in later slides, we're going for this sweet spot. And we can often find it because people will tell you when they've sort of gone past that middle point of the inverted U-shaped curve. So norepinephrine and dopamine are closely related in the prefrontal cortex. The norepinephrine transporter has similar affinities for both dopamine and norepinephrine, which means it can reuptake both norepinephrine and dopamine. And that there's a lot of dopamine happening in the prefrontal cortex. And so what we're doing largely with our stimulant drugs is we're causing the release of that, and we're also preventing the reuptake of dopamine and norepinephrine. Now, we do have some non-stimulant drugs for ADHD, and those are largely norepinephrine reuptake inhibitors. Those are things like bupropion is used in an off-label use, but we also have drugs like atomoxetine, and those will increase norepinephrine in the prefrontal cortex, but they don't increase dopamine in the nucleus accumbens, which is where reward is measured in the brain. So by avoiding that, we reduce the reinforcing and abuse potential of those drugs. So dopamine reuptake transporters, DAT, those dopamine transporters, take that dopamine up from the presynaptic, from back up into the presynaptic neuron from the synaptic space, just like a serotonin reuptake pump would do, but in this case, it's working on dopamine. And as that dopamine is released by those vesicles. So you're familiar with this model, perhaps from the early introductory content or the content on SSRIs. So in summary, we can think of ADHD as really being a continuation of that very early childhood inattention and hyperactivity that the person has not grown out of. So really, in a way, it's a neurodevelopmental problem, because what we would expect to have happen is that as the brain myelinates from posterior to anterior, that those circuits in the prefrontal cortex, which manage attention and focus, are not fully myelinated. They're not as functional as somebody without ADHD. And so we top that up, if you will, by giving stimulant medications primarily for ADHD, which cause the release of dopamine and norepinephrine, and also prevent the reuptake of those two compounds. So in the next module, we'll talk about those specific medications. So stay tuned. Thanks.